that has been fixed with an external fixator. The external fixator which we have used here is the AO external fixator, which has been used to fix a fracture at this area. The two pins that you are seeing here are the Schanz pins. Ideally, there should be two Schanz pins at least on either fragment. These are then connected to the tubular external fixator tube with this clamp, which is called the universal joint. The Schanz pin connects to the universal joint, and the final assembly looks like this, and it holds the fracture stable. Once all these nuts are tightened, there will be absolutely no mobility at the fracture site. This is another invention which has revolutionized orthopedics. Before the advent of this, the people who had compound fractures were immobilized in plaster of Paris, and holes were made in the plaster of Paris to manage the wounds. The plaster of Paris never gave a complete rigid fixation, which meant that the fracture site kept on moving, and over and above that, the plaster got soaked and spoiled by the pus. However, once the AO external fixator came into vogue, which is only for the past few years, the number of cases which have been going into osteomyelitis after compound fracture have dramatically been reduced. And this is another of the instruments that has revolutionized orthopedic surgery. This is not used for all fractures. It is used only for open or compound fractures in which there is a wound which does not allow you to either put an internal fixation or to put a plaster. Once the wound is healed, you immediately remove this, and either you put a plaster of Paris cast or you put an internal fixation and stabilize the fracture so that it can heal in the proper manner. The fracture of the neck of femur is one of the most important situations in orthopedics. Now, one thing to remember is that the fracture of the neck is very much dissimilar depending on the age group. A fracture of the neck in a child is a surgical emergency. In an old man, it is an elective procedure, and in a young person, it is an intermediate. In a child, if there is a fractured neck of femur, it has to be reduced immediately and in the best way possible. Otherwise, it will definitely go into AVN. Therefore, it is an orthopedic emergency. In a young man, you should do your best to achieve internal fixation, and there is a definite risk of avascular necrosis. In an old person, it usually will not heal even if you fix it. Therefore, in most cases, you go in for a prosthesis. Now let us see how each of these is done. This is the Moore's pin, and the Moore's pin comes with two nuts on these sides. Once the Moore's pin is inserted into the neck like so, another Moore's pin, or preferably two sets, are introduced through the same way until these nuts come flush with the bone. And once that happens, these can be tied together in such a way that it gives a stable fixation. So this is a Moore's pin. It is used in fractured neck of femur in children because the children have an epiphysis which may be damaged by the classic screw which you insert in adults. Remember that if it is smooth, it is most probably a Moore's pin, and the Moore's pin usually comes with two cylindrical nuts which are locked against each other to prevent motion inside and outside. The most important thing that you remember is that the Moore's pin is used because the neck of femur contains an epiphysis in a child. Suppose it were an older person, that is, in a young male, you prefer to put cannulated screws. Now, why do you use cannulated? Ideally, this is to be done under C-arm or fluoroscopy. Therefore, under C-arm, you pass a guide wire through the lower part of the trochanter and finally into the head until it reaches this part. You cannot see it in this model, but if this were a bone which are viewed under C-arm, you will see that this guide wire is now presently reaching up to the head. Through the guide wire, you put a cannulated screw using a cannulated screwdriver. Now this is a screw and it has got a hole inside. So it is a cannulated screw. With this cannulated screw, you put it inside and advance it into the neck through the trochanter, like so. Once it is inside and it is fixed in place, you can provide better fixation by 2 or 3 screws in the same manner. Once the fixation is achieved, the guide wire is slowly removed and the screw remains in place. The fracture is now stably fixed. Suppose this were an older person, a fixation of this manner would be useless, because no matter how you fix it, there is always a chance that the fracture will not unite. There are a variety of factors that disallow union of the fracture neck of femur in an old person, which you will find in your text. Now, if there is a fracture neck of femur, it usually occurs at this side. So, you imagine that this is the place where it separates. This is the head. Through an approach called the southern approach, because it was used in the southern states of America, you approach the posterior part of the femoral neck by splitting the gluteal muscles and cutting the external rotators and reflecting them to protect the sciatic nerve. Then you reach the portion where the fracture is and you extract the fracture and the total head from the acetabulum and remove it. This part is called the calcar femorale. It is on this calcar femorale that the prosthesis will come to rest. If for some reason the calcar femorale is not present, the prosthesis will not have a proper rest on that area, and in this situation you may have to use something called Thompson's prosthesis, which is used along with bone cement. You fill bone cement through this site, and before the bone cement sets, you insert the Thompson prosthesis. Now, the prosthesis that we commonly use is called the Austin-Moore's prosthesis, and it is again inserted through the same incision, that is the southern incision, also called Moore's approach. Once this part has been reached and the neck area is cleared in such a way that the calcar is standing, you ream the internal part of the femur and you insert this instrument. This is the classical Austin-Moore prosthesis. The Austin-Moore prosthesis is an easy instrument to remember because in Moore there are 2 O's, and the same 2 O's you can see here. These 2 O's or these 2 holes are used to insert the bone graft that you take from the head if you want. And after insertion, the bone graft provides a cross fixation for a stable fixation of the implant. This third hole is used for extracting the implant in rare cases. Let us see how this is inserted. Once the part up to the calcar is cleared and a cut is made in the manner that you want, you insert the Austin-Moore prosthesis like so and hit it down with the mallet with an interface to prevent scratching on the head until the shoulder of the Austin-Moore prosthesis comes to rest on the calcar femorale, like so. Remember that an Austin-Moore prosthesis is used without cement because it has got a good purchase here and it will not move. No matter how strongly you try it, it will not move. However, in cases where the calcar is weak or the calcar is broken, there is every chance that the Austin-Moore prosthesis will rotate. In these cases, you will have to go in for a Thompson's prosthesis and a cement fixation.
Now, we will discuss about screws in orthopedics. Judging by the look of what you are seeing in front of you now, you probably think that you are in some hardware shop. No, these are some of the instruments that we love to use in orthopedics. To an ordinary person, this looks like a mass of screws and mangled metal. But to an orthopedician, each screw is different and has its own use. When arranged properly and according to their properties, you have got many types of screws. And each of these has got its own different property. First, you have to differentiate between the cancellous and the cortical screws. You can see that there are 3 screws inserted into the soft cancellous matrix of this model bone. This and this. If they look similar to you, just see what happens when I try to pull each of them out. This screw should come out the most easy, just like that. This screw will offer a little more resistance. But this, it is very unlikely that I can pull it out of the bone other than by screwing it out. And finally, when there are a few threads, I can just pull it out with that much strength. So the question is, what is the difference between this screw, and this screw? First, let us see this one. This is a screw which you are very unlikely to see in daily life. This is the bolt for an interlocking nail. This is an interlocking nail and this is the bolt. The interlocking nail bolt is used only to prevent rotation of the nail and subsequent movement. Therefore, it does not have much use for the thread. It is very unlikely that someone will try or some force will try to pull this nail, the screw out of this nail or through the bone. The second screw that we have is this. This is a cortical screw. The cortical screw is excellent as long as it is inserted into the cortex, like so. And the cortical screw has to be tapped before you insert the screw. The cortical screw has got a thread which is sticking out of the shaft only for a very small distance. However, in contrast, you have a screw called the cancellous screw. The cancellous screw and the cortical screw have got very wide difference between their threads. Now, let us compare these two screws. This is a cancellous screw and we will take a cortical screw here. Now, you keep it on the lobby and you can very clearly see that both of them have got a clear difference in the thread size. The cortical screw has got a thread which sticks out very little from the shaft, whereas the cancellous screw has got wide wing-like threads. This is the screw that you want to use when you are trying to put something into cancellous bone, that is the soft medullary bone inside the shaft. However, if you are trying to fix the cortex, that is a plate or some other instrument onto the surface of the bone, and you are engaging the cortex